Good morning. Let's start with mood and affect, cognition, and stress and anxiety. These are three psych concepts you're going to have next semester. Each one of them will be a concept in and of themselves, so about 2 hours of presentation time. And you'll be taking care of patients on the psych unit. But we all know that these three concepts also go over all of our patients. They are with us all. So we are going to see them wherever we may be, on a med surg unit, in a clinic, whatever we're looking at. So some things you'll see in the chart are affective instability. That's if we're looking and we see in a patient, are they crying? Are they euphoric? Are they blunting? You'll see those words as instability. Their affect is not what they seem to be. It doesn't match their mood. Functional status is ADLs. Can they do things that during the day? Can they take a bath? Are they washing their hair? Are they brushing their teeth? Are they taking care of themselves? If they're not doing that, their functional status is affected. Melancholy is something you'll see um, in the chart that doctors will write that the patient is in a melancholy mood. So you may see that. Depression is when that person loses the loss of will. They may have suicidal thoughts. They just don't feel like they're functioning very well. Mania is that high and low. Hypermania, they're high. Hypomania, they're low. They may be depressed. So look for those types of things. Those are some of the words you will be seeing. So here is our page 2. This is our definition. The term is when the way a person feels, mood. Um, is the subjective data, the way they say they feel, the way they say their feelings. So when you walk in a room, how are you feeling today? I feel fine. I'm great. I'm in good shape. So it's what they're saying. Affect is that objective data. How do you see the patient? What are you observing? So is it congruent? Does it mean the same thing? I feel great today. They're talking, they got that higher tone in their voice, they're sitting up, they're smiling, or I feel great today. They're not that nonverbals telling us something, right? That tone that they're speaking in. Remember, communication. They may be slouched down. They may not have good eye contact. So we that's that objective part. Their affect, what we see. How does it effectively look? So mood is subjective. Affect is objective. Okay, so our definition, mood is related to the way the person feels. That's subjective, right? I'm going to tell you, I feel great. I'm in good shape today. That's what I'm saying. That's what the patient's saying. The term affect is the observed behavior, what we're observing, nonverbals, things like that, our objective data. So when we walk in a room and we see a patient and we're talking to them and we go, "How you feeling today, Pete?" "Oh, I'm fine. I feel great." They're smiling, they're sitting up, they got their hair combed, everything looks good. We know that subjective data matches that affect what we're seeing. Whereas you walk in a room and say, "I feel great today." They're sad, they're melancholy, they're not having good eye contact, their hair's messed up. That doesn't match. Their affect does not match their 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 mood, what they're saying they're like. So we're looking for those two things to be congruent. Um, so here we have a Unitarian model of what we're seeing, and you can see that you've got the lines there, that rhythmic part of the graph, right? So that's how we normally are. We get up in the morning, brush our teeth. We're getting going up the ladder. We feel better. We go get a cup of coffee. We're in good shape. We do all the things. We get ready. We're headed to work. Oh, well, got to go to work. Got our little coming down. We get to work. We look at all the things we got to do. Then we start to do some of those things. So we go back up. We get one thing done. We get another thing done. We're moving up the ladder, back up and down. But during the day, you're going to be faced with ups and downs. But we're in that eurythmic section. We're staying pretty close to in that eurythmia. When we become hypomania, or we're uh, bouncing around doing things that we shouldn't be, we're way up at the top, we're not sleeping, we're doing things all the time, or we get down into that melancholy, that severe melancholy down at the bottom, where we're depressed, we're not coming out of the rooms. We don't want to get out of that eurythmic phase of this Unitarian model. So we want to stay in the middle of it. Do you know anybody who exhibits these mood swings? Have you seen people like this? If we'd be in class, we'd talk about it. How would you handle a situation like this? We would try to educate the patient. We try to get them to do the things that they should be doing. So healthcare professionals, here's some of the words that you're going to see. Appropriateness, like I said, does the mood and the affect, do they do are they appropriate for the time what you're looking at? So if a person is told something sad, are they gonna look sad? Do they cry? Are they upset? Um, you find out you get 100 on your exam. Are you gonna be laughing? Are you gonna be smiling? Are you gonna be happy? That's the appropriateness. Inappropriate is of course the opposite, not doing the things that you should be doing. Um, Range, the two words you hear are broad and restricted. Um, the crying, okay, if it's appropriate to be crying, but you're so depressed, you're so down, and then when you come in and you say, hey, you did good on your exam, why are you crying? They get elated, they go up. It's broad, it's a wide range. It's not in that eurythmic part of that graph. Okay, full range means that they're able to show emotions and laugh and cry at the appropriate times that they're there. So they have that high part of the eurythmic phase and the low part, but it's still eurythmic. It's not outside there. Stable means they're staying in that eurythmic stage, staying in the middle of that graph. Labile, up and down, right? Just up and down. Can't really keep track of them. Then you've got the manic person who's always elevated, who everything's fine. Oh, someone's sick. Oh, well, they'll get better. They just stay high. They stay elevated. Depressed are those ones that are melancholy down in the bottom. No matter what you tell them, they're not very happy about anything. Um, Overreactive is once again another term where you see things um, that are not necessarily within line of the boundaries that they should be. Blunted is a very bad thing. Um, it's when you just don't get any change in that face. You don't get any nonverbals. They go, oh, okay, that's fine. They may not talk. They may just be looking at you. Um, that's really bad. That's when you really need to take that. That's a medical emergency almost. You want to let the physician know and try to find out what you can do for that patient. And then flat are people who just can't get them to show any affective things. They'll talk, they'll say good things, they'll say bad things. Um, they'll subjectively give you information back, but their face is flat. The nonverbal leaves. So those are the things you're looking for. And congruence is kind of, you want to keep things um, all matching each other. Congruency is matching, right? So look for that congruency in your conversations with your patients. Alterations in moods. These are the things we're going to see. Mainly what you're going to first see is a change in interpersonal relationships. Um, they just don't act the same. Family member will come to you and say, Pete's not looking the same, as he's not acting the same. He's not doing the same things. And then they'll talk about they're not able to complete their activities of daily living. They're not eating. They're not combing their hair. They're not. Some people don't even go to the bathroom. So they have accidents. So we're looking at things that are like that. You may see an increase in medical care from these patients. Um, so you'll see somatic complaints. My back hurts, my head hurts. They're constantly finding things that are wrong with them. And then anhedonia is when they lose complete interest. They don't want to do anything that's joyful. They stop eating. They stop talking. They stop watching TV. They stop going to church. They stop doing things that they normally would do. And then fatigue and sleep disturbances pop up. They're always tired. They're only sleeping a few hours a night. Things start happening. Of course, with all of this, you have an increased risk for suicide all the time. These patients are we got to look for things. So when you're studying next semester, you're going to study depressive disorders, which is signs and symptoms, sadness, discouragement, hopelessness. When they get to anhedonia and sleep disturbances, this is when we start to look at medications. How can we help that patient with some type of medication? Sadness, discouragement, you may be able to talk to them, see social workers, get things taken care of that way, in group sessions and all. The bipolar disorders, these are the people who are bouncing around, high, low, down below. They can't get out of the way of themselves sometimes, but then other times they function very highly. We have a lot of people who are bipolar diagnosed and high functioning. I mean, they get a lot of stuff done because they're constantly working and doing things. And then there's anxious distress is associated with both. They have a lot of anxiety a lot of times with these types of patients. So you'll be studying about these more detail next semester. Okay, so I'm giving y'all some screening tools, table 28.1. This semester, we're really not going to be looking at these. It's not testable material, but I want y'all to look over them because next semester, this is going to come at y'all hot and heavy. So just be aware that Beck Depression Inventory is a scale that you see clients complete almost anytime, anywhere. The mood disorder is 13 questions with symptoms and cluster, which look mainly at functional impairment. There's a child scale that you're going to see for younger people. The geriatric scale is used for the elderly. And then postnatal depression. That's a big thing that happens with postpartum depression. So those are the 5 big hitters out there that you see pretty regularly. So just be familiar with them, understand that they're out there, and like I said, you'll be talking about that a lot more. They'll probably have these on the units, and you'll be tested on this next semester. All right, our exemplar is assessment. So what do we do? What are we looking for when we assess the patient? We've got to get that mutual trust. We've got to get that therapeutic rapport. So we've got to use those open-ended questions that we learned in communication. Have that patient talk back to us, tell us what's going on, explain to us what's happening. We also need to be non-judgmental. Remember that this patient is not in control of this. Which seems like it's a mountain to them is just a little bump in the road to us. we're able to handle the things that are going forward. So we've just got to be non-judgmental with these patients and um, not not think judge them and say, well, how come you can't get over this? I mean, this isn't a big deal. We need to just have, talk to them, clear statements, verify and their understanding, and listen. Be good listeners. Have those Dumbo ears out. These patients sometimes can't focus, right? So short time intervals, 5 minutes, 10 minutes, maybe all we can get with them. It's very frustrating to a nurse when we can't do it on our own timetable, but we've got to remember that it's the patient that we're taking care of. So sometimes we have to do it on their time frame. Might have to go in, talk to them 5 or 10 minutes, see what's going on, then give them a break, then come back. And then refocusing. Remember, they're not able to focus. So we need to take our time to get them to focus on the topic at hand, bring them back on point, and, and, and make sure we understand what's happening there. And then assess for underlying metabolic issues, pain. Some of the stuff they're complaining about may be accurate. Maybe they are not um, feeling good. Maybe they're having high blood sugars, low blood sugars, hypertension. They may be having some breathing problems going on. So let's look at those things. Table 28.3 gives you some characteristics of mood disorders. I want y'all to be familiar with that. So look over table 28.3. Lifespan and cultural considerations. So we all know etiologically, whenever you look up any disease process, it's always one of the first things is age, right? So we look at their age. There's also that social component that we're looking at with history of family members who have maybe had these disorders. So that's, I don't have it up there, but that's that genetic component. So, so look at their age, look at their genetic component, and then culture. Culture is a big thing here. Westerners feel are very interpersonal, so they talk, they let their emotions be felt, whereas Eastern cultures and other cultures don't do that so much. Chinese, African, Hispanics, they report a lot of somatic complaints at a higher rate than Westerners do. They'll tell you more about their somatic feelings, what's going on with them. Latin cultures have a deep sense of tragedy. They sometimes feel like the world's coming to an end when they're not feeling good. We look at these cultures. We want to understand them. We want to look closely at them. Race is a big thing. African Americans and Latinos look to their families and faith communities more than they do outsiders. So there's a fear of hospitalization in those communities. So we've got to understand that we want to embrace them to get them over that hump. And then psychosocial, those are the things that are happening around them. What are their support systems at home? Do they really have a lot of stressors? Do they have good family relationships? Are they working? Are they not working? Do they have language problems? Are they in a new environment? What things are they facing at home that we've got to understand? So ask those questions. A good psychosocial evaluation and assessment is vital no matter what you do, whether you're taking care of a patient like this or you're taking care of that diabetic. You still have to have a good psychosocial. All right, diagnostics. So before we can peg a psych diagnosis for depression or bipolar, we've got to make sure there's no underlying events that are going on. So doc's going to order a panel of tests just to be sure. Thyroid functions, they remember that a hypomanic person is going to be depressed, tired, going to be gaining weight, things like this. A hyperthyroid is going to be bouncing off the walls. You could be thinking they're bipolar if they have a thyroid issue. Um, so we're going to do a thyroid function test just to be sure. Um, by now, you know that electrolytes are a big part of our life and what's going on. Sodium is going to, cognition-wise, sodium is the big electrolyte there. Um, so you're going to look at those panels, those electrolyte panels, make sure we're all within normal limits. Your analysis and toxicology, what are we looking for there? We're looking for drugs, right? We're looking for tox screens. We're looking for urinalysis, making sure they don't have that UTI. Um, Grandma may be perfectly fine. Then she's totally disoriented in an hour or two. She's going septic on us. We've got to get a good urinalysis and make sure things are going well there. Toxicology is the screen for drugs. So we're looking for any type of drug disorders. Liver function, when your liver goes out, the ammonia levels increase in your body and you don't act right. You act like you're drunk. You act like you're kind of crazy. So we want to check those ammonia levels and we want to check those liver functions. Kidney functions, that's BUN and creatinine, they're so important also with the breakdown of protein and being able to clear all of the, the necessary components out of the body. And ladies, last but not least, we all know pregnancy, hormone shifts, right? So we want to do a pregnancy test on women who are in childbearing age, just to be sure we're not looking at any of any type of hormones that are going on that may be swinging because of the pregnancy. So look at all of these diagnostics, be familiar with them, understand that we want to rule out anything underlying that we may be able to fix with with regular medication instead of going into our psych meds. All right, so let's look. That's mood and affect, down and dirty. Does mood and affect any of these concepts? Their behaviors, cognition, health and wellness, communication. We talked about spirituality, immunity. Remember that if you're not feeling good, you're not doing activities, exercising, getting out there, your immune system is affected. Stress and coping is a big thing here. A lot of stressors make these people feel like this. We'll talk about that in a little while. And then we'll always be teaching and learning, okay? So remember that all of these concepts are interrelated to mood and affect and um, can affect them just like anything else. So be on the lookout. And you're writing care plans. You could write care plans under um, any one of these concepts when you have a mood and affect diagnosis. All right, let's start on cognition. Some of the words you're going to hear is perception. What does the person think about their environment, their perception, or do they realize it's daytime, nighttime, their perception, that it's a beautiful day, that it's a rainy day? What are they perceiving about what's going on? Memory refers to retention. We got short term, midterm, long term. So what did you eat for breakfast this morning? Short term. You know, do you remember the football game score last Sunday from the Saints or from the Pelicans or something like that? That's midterm, midline. And then, of course, long term is, do they remember things that happened in the past? Who is the president? Who was the president before Trump? Um, Something like that. We want to check those different types of memories. And an executive function is that higher level of processing, flexibility, adapting, being able to be goal directed. So that's one of the things we are as human beings, having that executive function, being able to move on our own and to do the things we need to do and to be goal directed. Are they doing that? So those are some of the words you have to understand on cognition. So here's our definition. It's the process that embodies perception, attention, visual, spatial, language, memory, executive function, higher orders, problem solving, reasoning, decision making, metacognition. A lot of big words there, right? A lot of good words we can use in charting also. So um, we've got to look for these things. These are the assessment points that we're going to be looking for when we're talking to our patients. Um, so it's a good, we've got to understand how these alterations are and how they affect our patients and that we're taking care of. So look for the different ways. We'll talk about the risk factors and assessments and things like that, but that's our definition. So normal cognition is, you'll see this in figure 23.1. Normal cognition is our perception. What are we seeing? Proprioception is that motor function, that special awareness. So, are we moving properly? Are we full range of motion when we walk, when we talk, when we do things? That proprioceptive motor function and awareness around us, that special awareness, that sense. You ever sitting in a room and someone's outside your field of vision, but you feel a presence there? Something going on. So that's that special awareness that we have. Orientation, person, time, place, those types of things are what we're looking at with orientation. Attention, we remain awake and alert. We can be seen, we can be heard. Um, we're able to follow what's going on and thinking and doing problem solving. So that's when we're looking at attention. Memory, it's retained, it's stored, it's retrieved. So you know, sensory, we should be able to respond pretty quickly from a sensory mode. So we should be able to hear, basically receive the message, remember, and then we should be able to send a response back. There's no lag. That's that sensory component. If there is a lag, that means there may be a hearing issue. There's a processing issue going on in the brain, right? So if I ask you, how do you feel today? You should be able to respond, I feel great. I feel fine. If you get a patient that goes, how do you feel today? And they pregnant pause, nothing there for a few seconds, they're processing that. And if they're having to process it longer than they should, that's a sensory component of memory. Okay, we talked about short term and long term before. Communication and social cognition, that's receiving, interpreting, and being able to respond appropriately. So we want to make sure that they have the social cognition to be able to do those things. Motor coordination is planning. Um, if they have something to do, if they have goals for that day, what's their plan to get things done? Well, I'm going to get up today, I'm going to eat breakfast, I'm going to go for a walk, I'm going to take a shower, I'm going to come back and take a nap, I'm going to eat lunch because I want to go home. Okay, so we're looking at their planning, their organization, being able to take care of complex motor tasks. Those complex motor tasks are like doing puzzles, doing crossword puzzles, putting puzzles together, being able to put the pieces together. Executive function is planning, completing complex tasks. Okay, so um, being able to have a good plan, similar to what I said before about planning your day out, making sure you're doing all the things that you should be doing. If you don't complete those tasks in that first day, what will you do to fix it the next day? Intellectual capacity is being able to learn, to reason. So if I go in there and teach them about insulin, are they able to understand it, repeat it back to me, and do I have a high confidence level that they can take care of themselves? And adaptive behavior is, are they adapting to their environment? If they're sick, are they responding appropriately? Are they trying to get better? Or do they just not care? So can they adapt to the stressors, the things that are in their life right now? So adaptive behavior is a big part of that patient being able to take care of themselves and to move forward in the plan of care. Okay, here are our risk factors. What's our population at highest risk? What do you think? Um, the elderly, right? Their elder abuse, things like that. Women with poor health status or dependency, lack of social support, they are our next population. Um, and men with a history of chronic disease processes like strokes, diabetes, hypertension, they have a higher risk of cognitive disorders. Personal behaviors. What do we think about personal behaviors? Those are the things that we do on our own, right? So, I mean, any type of risk-taking behaviors like adolescents do, people who like to drive fast, people who like to ride motorcycles, people who like to daredevil and go climb mountains and all, they are at a higher risk because they could have traumatic brain injuries. Or what about the people who self-abuse? What about the people who are drinking, drug addicts and things? They're at a much higher risk for because they just lose that basic sense of safety that they have. Learning disabilities, of course, those are anybody who may have Down syndrome, Fragile X syndrome, fetal alcohol syndrome, the mom who comes in who's cocaine dependent. So these are all risks that we have from our learning disabilities. Um, but we also know that this population and it can be helped, and we need to be out there looking for them. Dementia, of course, that's that loss of cognitive function over time, and we see a lot of that since we have a much older population out there now. Since our lifespan is increasing and we're going into our 70s and 80s and even into our 90s, we see patients who are coming in with dementia. So we want to be able to take care of those patients. And then remember, there are a lot of health conditions. If you're in pain, if you don't have enough blood sugar, if you don't have enough oxygen, you can have these types of cognitive impairments because of the situation you're in. So we want to look at those health-related conditions to understand that before we peg someone with a diagnosis of a cognitive mental disorder. So when we assess our patient, we've got to prepare them. We've got to let them know that we're going to be talking to you for a little while. We want to understand. We want them to understand that that we're the person. The nurse is the person who is really there the most with them and going to help them the most. So you want to be able to put them in for them to be comfortable with you. So make sure the room is in good shape. You know, it's not too cold, it's not too hot, it's not too noisy. The patient's comfortable before we begin any type of assessment for cognition. Um, Position the good position to for the patient to be able to see you, to understand you. You don't want to be standing over them. You want to be at eye level with them. You want to be able to have good eye contact with them. Then we've got to understand, do they have language skills? Do they understand our conversation? Are we talking above their limit, their grade limit, or we had a fifth grade, third grade, college education? So talk at a level that they're able to understand, and also um, at a level that we're not talking down to them. Okay, and can they respond back to us? Remember, can they process it and get it back to us um, when we're able to talk to them? Do they understand what we're saying? Then we want to check awake, alert, and oriented times four, right? Are they here? Do they know where they are? Do they know what's happening? Um, Memory, we wanna check that long term, midterm, short term. Ask them questions that'll check that ability. Um, Computational ability, you'll learn a mini mental uh, test that you're going to give your patients next semester. One of the things they say is count backwards by seven. So, okay. So, 93, 84, um, 77, 70. Can you go back in a normal tone and get back to zero? That hyper person, they may be able to do that like in 20 seconds. That hypomanic person, or that melancholy person, or that person who is having trouble doing that higher function, they're not going to be able to do anything. So computational. And then we talked about mood and affect last time. So what are their emotions? Are they labile? Are they able to communicate with you? Or are they in that eurythmic part? And then their perceptions. Are they complete? Are they rational? Are they pertinent? Do they seem to be aware of what's going on? So in your book, page 1590, you should have some interview questions you should be familiar with. Um, so look at those. And if you have any questions, let me know. Delirium is our exemplar, and it is basically characterized by confusion, rapidly changing mental status, disorientation, personality. It's usually delirium is not usually. It's a result of something that's treatable. Um, that's something of a form of treatable physical or mental health problems. So um, look down at the bottom of this page in the PowerPoint. You'll see words that you may see associated with charting with delirium. So restlessness, that lint picking, lack of muscle coordination. They may have difficulty in swallowing, that dysphagia. Um, they may not be able to name people. So you walk in the room and you say, "Hey, how you doing? Who are you?" "Well, I talked to you this morning. I'm Pete. I'm your nurse." "Well, I didn't see you this morning." They've lost that. They can't name people. Um, Inability to express themselves, that aphasic thing, and they might start echoing, that echolalia, where you repeat the sounds. They'll go la la la. They'll be saying things back to you, echoing what you're saying, because they can't process. So how are you feeling? How are you feeling? How are you feeling? I'm asking you a question. How are you feeling? They're not able to process that. So be familiar with that terminology down there. Could be test questions, right? So remember, you got to understand those terms. Um, but it's usually something that can be fixed. It may be it may be something that's underlying that we have to find out what needs to be done. So when we look at the signs and symptoms we're going to see, table 2310 gives us those signs and symptoms. There's reduced awareness. They don't have attention span. There's impaired thinking. They're disorganized. And there's changes in behavior, hypoactive, hyperactive, hallucinations, things like this. So we want to understand the progression. When did it come on? Is it sudden? Is it severe? Is it deteriorating? Usually this this can be fixed, and it may be a matter of hours. It may take a day or two. It may be longer, depending on what the problem is. What are the characteristics? Do they are they temporary? Can they be reversed? Can we see other signs? Are we seeing the signs of restlessness, those motor signs, tremor? Um, have they slowed, or have they raced up? Are they more hyperactive? Um, what's their effects on their speech? Is it slurred? Is it disorganized? Is it non-sensual? Um, you know, these are things that will manifest themselves. Um, what are their mental status? Is their attention fluctuating? Is it fleeting? Um, when we walk in that room, we can see all of these things. Do they have any visual, auditory, or tactile hallucinations? Are they feeling things crawling on them? Are they seeing the little rabbits up in the corner because of the medication they were just given? Um, and you have a patient who was in that in a good space mood wise, and then you walk in and all of a sudden they're paranoid, they're anxious, they're very irritable. um, these are all signs and symptoms that delirium has set in. Something is happening. And then systemic involvement. um, have they been exposed to something that's not, working right with them? Mainly drugs, right? I mean, we're giving them medications. They could be taking a medication they've taken for 20 years, 30 years, beta blockers, calcium channel blockers, ARBs, different things like this. And all of a sudden they're having a reaction to them. So it can happen, it does happen. And one of the big things we have to do is be on the lookout for this. Okay, how do we assess them? Well, we look at them, we observe them, right? We do a patient interview. We look at their past medical history. We do a nice head to toe. We check for fever. We check for infection. We check for inflammation. We we go through and we wanna see what we can find that maybe cause this change, this way that this patient's deteriorating. Like I'm saying, it could be fast, or it could be the astute nurse catches it quickly, and we start to do things and try to figure out where they're going. What have they eaten? What have they drank? What medications have they taken? Um, you know, we want to do all of our good physical signs that we can look at, our vital signs. We're going to do SpO2s. We can do blood sugars. Um, we want to look at other things that have touched this patient. Um, we also want to understand. I mean, if there's someone who came in to visit them, it could be something that was said in the conversation. So good psychosocial too when we're looking at this and trying to put the pieces together. Doesn't necessarily have to be a family member either. It could be the physical therapist. It could be the lady who brought lunch to them. So there's something going on that has changed this patient's um, uh, perception about what's happening here, and we as the nurse have to find out exactly what is causing that problem so that we can fix it. Because remember, delirium is a fixable process. If we find out what's going on, we can fix it. So once we've done our assessment, we're going to implement what needs to be done. So we want to make sure we create a safe environment, that if there's anything harmful or anything that could be causing problems, we want to be sure that we help that patient from wandering, minimizing fall hazards or fire hazards. We want to orient the patient to time and space. We want to use a simple calendar of pictures to help them um, to learn what's going on. We're going to limit that stimuli. Um, they can be overwhelmed by too much light, too much sounds, too many things that are going on. Educate them. We should talk to their clients, to their family members, make sure they understand their diagnosis, make sure that they understand the course and the things that are causing the disorder. Um, we need to just do a good job with that with that education process. Then we want to preserve the client's dignity. Because of these alterations, they may not comprehend social and be able to communicate like normal. They're at a greater risk for being ignored, exploited, or mistreated. So we've got to look out for those types of things. Their dignity is, of course, a big thing. Um, Collaboratively, if this is going to take longer than the time that the patient's in the hospital, we want to be able to use other resources that are out there. So the government may have programs for this depending on their age and their diagnosis. Look at their Medicare, Medicaid, Social Security benefits, things that might be helpful to them once they go home. Um, there are all kinds of agencies, non-governmental agencies, organizations for Alzheimer's, dementia, kidney problems. So there are a lot of community outreach types of things that we need to look at. We can depend on their religious conviction, their community, back at their religious community. How does that work? And and then pharmacological, what types of meds are we giving them to keep them moving forward, to keep them on the right path here? So, so it's all important for us uh, to follow through with these types of nursing implementation intervention. So independent, right? The things we can do without any need for um, uh, any type of orders, right, are the ones that we have up there: independent, collaborative, or community, like we've said, and pharmacological, or of course, doctor's orders, right? So we're at the end of cognition, short and sweet. We see here these are our interrelated concepts. Once again, fluid and electrolytes, teaching and learning, stress and coping, sensory perception we've seen there, mood and affect, perfusion, oxygenation, health and wellness, communication, inflammation. All of these processes can affect us, right? Fluid and electrolyte imbalances can cause intracranial pressures, disruption to O2 transportation. Inflammation is vascular permeability we've got to be looking at. It can affect brain chemistry and cognitive impairment. Of course, we know oxygenation. If you don't have enough oxygen, we can run into issues there. Perfusion also. The brain is one of the biggest organs in the body that needs oxygen. It takes up the most oxygen consumption of any organ in the body. So it's so important to keep that oxygenation going and to keep that brain in good shape. So recognize that, once again, doing any type of care plans for your patient, you can use almost any one of these concepts to prepare a care plan for a patient with cognitive issues. So we're on to stress and coping. We got to do a good cognitive appraisal, right? That's what we had last time. So mood and affect, cognition, they are all affected by stressors, right? And the ability to cope. Okay, that person who may be depressed may have too many things coming out at one time. What are their coping skills? That cognitive impaired person may not be able to understand what's going on. So cognitive appraisal of your patients, okay? And we want to be able to look at those things that are out there. The stressors are disruptive forces, right? So we've got to appraise it. And we need to know that it may not just be associated with the patient. It could be family members, it could be lifestyles, it could be a lot of things that are out there. So we want to look at that. We want to understand what their coping mechanisms are, how they can handle these types of things. We want that equilibrium, right? We want that to be in that eurythmic part of that mood and affect thing that we looked at the beginning. So make sure we do a good cognitive appraisal for your patients to begin with. So stressors are any type of external influence that disrupts equilibrium. Okay, equilibrium is that homeostasis, that ability for the body to be stable, to have a good internal environment. So anything that challenges that posed by anything external can cause stress. Okay, so we want to understand that stressors um, anything, and our coping ability is to get back to that homeostasis. So we want that balance. We want fluid and electrolyte balance, oxygenation. Those are all physiological things that help us to maintain homeostasis. Psychologically, the stressors may be physical, where we can't do the things we used to do. We can't mental, it may be we're not prepared for what's coming at us, like this COVID-19 placed a lot of additional stressors on us. Um, and they may be emotional. How do we react to these things? So by definition, we're looking at a stressor and what is the coping mechanism? So how do you perceive it? How can you overcome the issues? Two types of stressors, table 31.1, are biogenic. Those are things that will affect us directly. So examples, caffeine, nicotine, temperatures, outside things that trigger stress responses. How do we handle those? Psychosocial are our environmental needs that are out there. Um, Anything else that comes at us um, is a psychosocial stressor. Flat tire in the morning when you're getting ready to go to school, tests that are coming up, exams, um, financial issues that you may have. These are all psychosocial problems that we have to face and that we have to understand what we're able to take care of. So table 31.1 gives us the different types of stressors. So be familiar with that table. Continuing with types of stressors, they're the daily hassles, the things that we look at that are there every day, roles of living, our bills, our work, our traffic, our neighbors. Um, During these times, there are people who come knock on our door when we're self-isolated with this COVID thing, and I go, oh my gosh, look who's here. Not a good thing. I feel like they'll be here for the rest of the day, right? um, whereas other people I look forward to seeing. So depends on the daily hassles, things that are around you. Internal, those are things that we get just day-to-day work, school, um, having to take care of your children now at home because the schools are closed. Any type of spiritual or physical or emotional things that are affecting you. Not going to church, right? I mean, those are big things internally that change the way we look at things. Environmental will be things that are out sometimes, um, outside the realm of what we can do. Like people are unemployed now. Your graduation may be set back because of this. There's really not a whole lot we can do about those types of environmental stressors, but try to work through them, take it day by day, and move on to um, to the next step forward to see where we'll go. They're usually a little bit more long term when you're looking at environmental. Um, so be familiar with those. Box 31.5 has some good examples of daily hassles. The coping process. These are the way we look at how we would look at things. So that good cognitive appraisal. How is that patient mood and affect wise? Are they in that eurythmic part of the grid? So can they handle the pressures? When they're down at the bottom of the eurythmic thing, can they have the coping mechanism to get them back up to the top? Remember Maslow, hierarchy of needs. If we don't have those base bottom things covered, if they're not eating, if they're not taking care of themselves, they're not having bowel movements and urination and things like this. That's a pretty hard way for them to cope if they can't take care of those things. Um, Effective coping, there are a couple of ways you look at that. Table 31.3 gives you some examples of that, but problem focused is usually things we can fix, right? Like I walk outside, there's a flat tire, oh my gosh, I'm at the bottom of that eurythmic thing, I gotta get the thing out the trunk of the car, I gotta jack the car up, I gotta take the old tire off, put the new tire on, but I can fix it, right? It's problem solved, problem focused. Emotional focused are a little bit tougher. It's usually involving people and emotions, and um, when you get that dynamic going, how are you? How you don't know how that other person's going to act. You throw something out, you see if it works. You come back, you work through things. So they're, they're usually people feel are beyond their individual control. Um, so um, it's got to be worked on. It's a little bit harder. So look at table 31.3. Um, and if you have any questions on that one, let me know. Um, and then we are constantly reappraising and adapting, right? So I walk outside. The easiest thing is to cut the tire on the car. I walk outside. I look. The jack's not working. Now I got to reappraise. How am I going to fix that? What can I do to get that off? Or I don't have the tire tool in my car. Or I can't break the nuts off. It's too hard. They're rusted on. So different things like this, reappraising and then adapting to what just happened to you. So, so you do cognitive appraisal, you look at that Maslowian hierarchy of needs, check their coping abilities, reappraise, and adapt. Is the patient able to do that? That's the general coping process. There are two theoretical models we're going to talk about. The general adaptive syndrome, that's figure 31.2 and 30, 31.2 and 31.2. I doubled that up, huh? Okay. So they're in 31.2. I got that 3 times on there. Anyway, the general adaptive syndrome or process, you might have had this in biology, but basically you go through that first phase, which is alarm. Oh my gosh, there's something wrong. I have a flat tire. Then you go through your that's your shock phase, your counter shock phase. You look at things that are happening. What are you going to do? How are you going to handle this? What's going on? Then there's a stage of resistance, which um, you're working back towards that homeostasis, but you're still going up the ramp, right? So I got the tire tool out, I got the jack out, I'm jacking the car up, I'm sweating, I'm hot, I'm not happy. I take the nuts off, I pull the old tire off, I put the new tire on, I start to jack the car down, everything's great. So I'm coming back down that resistance phase. You see where I'm coming on the other side. Then the stage of exhaustion. I'm finished, I'm done, got to go wash my hands, maybe take a shower, take the flat tire in to get fixed, um, things along those lines. So that's your general adaptive. It's kind of more biological, that fight or flight type of thing. The transactional model is more a psych model, okay? So we go in and we do our primary appraisal. And the primary appraisal is, does that patient know what the stressor is? Do they understand what that stressor is? Can they tell you that what's going on? I have an exam tomorrow. That's my big stressor, okay? The secondary appraisal is, how are you going to cope with that? What's your plan? What are you going to do? You know, do you have a good plan? Well, I've been studying. I've done my SLOs. I've done my little outlines, like you said, Mr. Keller. I'm, 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 I'm still stressing about it. So, but are you in that resistance phase? Are you doing something to handle that stressor? So we want to make sure they have a good plan, a good coping resources, potential objects they can use. And then we have to let you go through that. We have to, go and study, go do the things you need to go and do, that potential um, to to use those coping resources and come out on the other side. Then reappraisal is, did it work? Do you feel good? Do you feel comfortable? Did it work? If it did, great. If you're still stressed and you've got, not as stressed as you were before, let's reanalyze it. Let's reappraise it. Let's find out, okay, you've gone this far with that stressor. How can we change our coping mechanisms to get it to come totally under control? And then you keep going back and forth with this. So that's a lot of what happens on psych units. You bring them into group sessions in the morning. They set some goals. They set some aspirations. They go to have a little break. They may play a game. They may go do some things. They come back to a group session. You reappraise them, see that they're moving forward with their progress and that type of thing. That's the social workers aspect. The nurses aspect is we're constantly looking at the patients. Did they get up in the morning? Did they go take their showers? Did they go eat their lunches? We're looking at those Maslowian things that they're having to take care of. So those are our models, and you need to be familiar with them. So our manifestations of stress, I think y'all will all agree, um, fight or flight, right? That's what we're looking at, that sympathetic nervous system. So what happens? Respiratory wise, respirations go up. Cardiac wise, heart rate goes up. Integumentary, we sweat. We start uh, to tense up. We get anxious. GI wise, well, that's a mixed bag here. GI and urinary. Test time, what do y'all think about? Your stomach's upset, you're queasy, you may not feel good, you got to go pee a lot, or it could be exactly the opposite. When I'm stressed, Mr. Keller, I don't go to the potty, I don't do things, I tighten up. So it could be either side of that. Ophthalmic, we see better. It's everything's amped up, all our hormones are up, we're focused, we can see better. Neurologically, if we're not too anxious, we should function better. We should be able to think better. Musculoskeletal, we are tense. We're ready to fight, right? We've got those muscles trained and ready to go. And then endocrinology, you're releasing glucocorticoids into the bloodstream, which causes glucogenesis. Big words, right? But you're actuating blood glucose into the blood, so you can have the energy to be able to face the stress that you're dealing with. Now, once again, these are good when it's over a short term. If a person's constantly stressed, what do you think? If they're breathing more, if their heart's working more, if these hormones are in their bloodstream more, if this glucose is in their bloodstream, it's not good. It's not a good phase. It's not a good sight. So so we want to be aware that these manifestations do take place, and figure 42.1 and 42.2, 42.1, 42.2 are what you're looking at in the book. So the last slide we saw were physiological indicators, and psychological indicators are what we're going to talk about here. So fear is that apprehension. It's perceived safety or wellness that we are thinking that's being inhibited here. Um, so we're thinking it may be a dangerous event, it may be some painful stimuli that's causing these issues. So it may be memories of things that have gone on. So we're concerned about fear in the patient, or is the patient afraid of what they're looking at? Anxiety is apprehension. It's mental uneasiness. You're saying, I just feel helpless. Um, so it can be perceived or it can be actual, but we're looking for that anxiety level. What are they feeling about? That's our exemplar. We'll talk more about that. Anger is subjective. It's displeasure, it's irritability, it's animosity. It's just feeling bad towards a person, a thing, an event, something that's making us angry. And then depression is when we get to that feeling of emptiness, hopelessness, sadness or despair, that apathy that we may start to feel. So usually when you see this, you start to see activities of daily living start to be affected, where the patient's not doing the things they normally do. And there are things that we look for. So look at table 31.5 for examples of this depression and manifestations that you may see, and be familiar with that. But these are our psychological um, manifestations or signs and symptoms, another term for manifestations that we see in the patient with stress. Cognitive indicators. These are the ability for us to be able to do a cognitive appraisal of our patient that is showing signs of stress. So, can they problem solve? Can they identify potential steps to resolve the situation? Um, and then, if they can they implement them? Can they make them come to pass? That's what we're looking for. Um, we're looking at that cognitive structuring. Is that mental process to make that environmental stimuli work for us? Can they structure things properly, that higher functioning, that executive function of what's going on? Suppression is a defense mechanism. A lot of times people just push things down, just don't even think about them. And their coping mechanism is if I just ignore it, if I suppress it, it'll go away. So are they using suppression of these stressors that are out there? Self-control is just the ability of that patient to be able to not get out of that eurythmic phase, that they're able to restrain themselves from acting, that they behave in a manner that keeps them functioning and moving forward towards the goals that they have processed for them. Fantasizing, sometimes we want to daydream. We want to look at a picture down the road and thinking more favorable thoughts about the resolution. So fantasizing is kind of a defense mechanism that we have, and can be helpful if we use it in the right light. If we use it positively and say, one day I'll be through this and I'll be able to get back to where I want to be. Um, the other thing about fantasizing that would be a bad way, a bad defense mechanism, is just to say, la la la, life goes on. The little elf's going to come and sprinkle pixie dust over this and we'll be okay. Well, there aren't any pixies out there that sprinkle pixie dust. We've got to solve the problems ourselves. So that fantasizing could be good, could be bad. Just like suppression could be good, could be bad. If we're so stressed and we push it down, and then, like I said, remember we take little bites of the stressor and we fix a little bit of it, we reappraise it, we come back until we reappraise again, we take some more little bites, and we keep going at it until we ultimately take care of things. So look for a good cognitive appraisal and a good cognitive understanding of how to handle these stressors. Ego defense mechanisms. These are on table 31.4 and 42.3. This one we usually have fun in class, right? I ask y'all to give me examples. So compensation, okay? So Pete Keller's compensation. I was in school, I couldn't play football. I was a little wimp, I wasn't a big guy. What did I do? Tick tock. Y'all answer. What did Pete Keller do to compensate in high school? What did I do? Um, I became the photographer for the yearbook. Yay, yay, yay. Yeah, I was the photographer. And guess what? When I was a senior, I got my letter, my Rummel letter. and I got a jacket just like the football players. Big man on campus, right? I had a little camera in my little arm on a football. Anyway, I compensated, right? That's what I did. Denial, what is that? That's when that patient, the best one here is that metastatic cancer. That cancer patient saying, this isn't happening to me. I still feel good. I haven't felt that bad. I really don't know what I'm doing. I'm in denial. I'm denying it. Displacement is when you displace it, when you blame somebody else. I failed the test because Mr. Keller didn't teach it. Well, you didn't fail the test because I didn't teach it. You failed the test because you didn't study. Okay? So displacement is trying to push it off on somebody else. Um, you have to take control of that and understand that it is the stress. You have to solve those stressors yourself. Identification. Identification is finding someone who's a role model who you want to emulate. Okay. So identification, the nurse student imitates the nurturing behavior of one of her instructors, using them with the client. So finding a role model out there, your preceptor, another student who has good study habits, things like this. Okay. Intel, intellectualization, big words, a lot of syllables. Um, that's the person whose parent had a stroke, and a couple days later the patient dies, and you go up to that. I'm so sorry to hear that. I'm so sorry to hear about your dad, your mom, your loved one. Um, and they go, oh, that's I feel good. Daddy would not have wanted to be a vegetable all his life. We are intelligent, using intelligent, in, well, whatever that big word is, to try to overcome that stressor. We don't know what mom and daddy wouldn't want it to be. They might have wanted to be here for another 6 months if it was left up to them. Um, but anyway, that's that terminology. Introjection is when we introject into someone else. So that 7-year-old telling his little sister, don't talk to strangers. He's introjecting his values into that sibling that he has. So you can get introjection from other people. Minimalization, that's you know, um, the one in here, what I've had 3 drinks. I'm not drunk. You're minimalizing things. You're pushing things down, making them not seem as bad as they really are. Projection is that mother who blames somebody else. The baby's crying in the store as a 2-year-old, a little toddler, and she gives them a good bop on the bottom, and you look at them and you're going, oh my gosh, you shouldn't be spanking your baby. And she says, I'm not spanking my baby. He has a diaper on. He won't feel it. Well, that's not true. I mean, that child, it's not the physical feeling that child has, it's the emotional feeling that child has that we're doing with. So projection. Rationalizing is well, wait, I think I got those two messed up, right? The mother spanks the toddler. That's rationalization. Projection is the mother tells her child um, that the one, what's it say? A mother is told her child must repeat the grade in school. She blames it on the teacher for instruction. So I guess I'm repeating myself here. And then regression is when that adult throws a temper tantrum, doesn't get things his own way. Okay. Um, so so repression. Be familiar with these. That table. There's some. I got table 31.4, 42.3, 31.6. There are a lot of examples in your book, um, and you will get a question. Maybe not this test, the final, but you need to know these different defense mechanisms. Okay, so they're not hard. I'm not going to throw anything at you that you can't handle. So just be familiar with them. Assessment. What do we do with assessment? 31.3 gives us a good idea of what we're looking for. So behavioral, cognitive, emotional, physical. What are we looking at? What's our patient's health history? What's their current and past illnesses? What are their physical complaints, those somatic complaints, those things that they're not feeling very good with? What do they look like? Their general health history. Are they compliant? Do they do the things they're being told? Are they are they working with the things they need to get better? Um, and then we do that stressor. We do that primary appraisal. What are your stressors? What do you feel like are stressful incidents that we need to address? And how is it manifesting? You know, is that person so anxious that they're not eating? What's their level of anxiety? Um, and what are your coping strategies? Are their coping strategies? How are they looking at them? We want to look at that verbal. Can they be able to express themselves? Because a lot of times the problems come in and that patients are internalizing. They're not letting things come out. So we need to have a good verbal sense there. And then motor, can they walk? Can they well, not walk, but are their motor functions intact? Can they be able to perceive, to hear all the physical stimuli that are out there? These all are very good ways to cope, okay? The environment, too cold, too hot, too bright, too noisy. Those things will help us cope by controlling those things that are around us. And cognitively, what are they looking at? What are the things that are caused? So we're looking at a good assessment, behavioral wise, cognitively wise, emotional and physical assessment of these patients that are in these stressful situations. First exemplar we have here is adjustment to health and illness. So we're looking at, when we look at this, this is when people become sick. This is when people become debilitated, when we're taking care of the patient. Normally a nurse doesn't see a patient, right? I mean, when you're healthy, you're wealthy, you're wise, what do you need a doctor for? What do you need a nurse for? They need us, they need things when they're not doing so good. So there's an adjustment to health and illness, right? So we want to look at things. We want to look at what's going on with them, physical wise. Are they sleeping right? Do they have good sleep patterns? What are they doing eating wise, nutrition wise? Y'all learned in metabolism how much food affects us and what's going on. And a big, big bugaboo with everybody in this world, everybody in this room, everybody that's out there is time management. So do they know how to do relaxation techniques? Can they actually take time out to relax? Can they step away from things and kind of go into a little world where they can take some deep breaths and relax? Do they know how to do that? Do they have good support at home? Are they able to, do they have family members who support them? Do they have a good infrastructure where they've got a good job where they can have the money to pay their bills? We want to validate their feelings because they really, they're in a new space, they're in a new area, they have a disease process going on. So we have to validate those feelings and understand that we can get them healthy. Might not be back to where they were before, but they will be healthy again to the best of our ability. What are their coping mechanisms? They're going to have some bad things that we're going to have to say, maybe that's not such a good thing to be doing. They'll have good coping efforts that we want to reinforce. And always, always, always offer hope. Offer, light at the end of the tunnel. Let them know that they're doing a good job. Praise them when they do good things. You ate all of your breakfast. You got up and walked today. You took a shower today. May seem like little things to you. Thank you for helping me today. You've been a great patient. All of these words of encouragement are things that get that patient moving in the right direction. And then, lots of times we do a lot of good things. We just don't take credit for them. You know, we study hard. We learn how to do things. So when the patient is got successes that they've done, just like I say, it may seem like a little thing. They drank their juice, and it's the first time they drank their orange juice in a week. That's a good thing. So look at the little things, identify their senses. And then we want to look at time management. How are they managing their time? How are they doing things? Um, and so we also always look for those collaborative pharmacological things that doc may have, counseling, there may be physical therapy, psychotherapy. Um, they may have to be doing other things that are ordered in order for them to move forward. So anxiety is the next exemplar. It's an alteration to the human condition of impending doom. It may be real, it may be imaginary. It's always accompanied by those autonomic responses and a protective mechanism. So it's normal. We all are anxious. We all have anxiety. Um, and anxiety is not a bad thing. It's a continuum. Mild anxiety is sometimes good. We'll talk a little bit about that um, in the next slide or two. But it's an alteration. It's a change in our human condition. And how are we going to cope with this anxiety? Clinical manifestations are signs and symptoms, figure 31-7. You're going to have sleep disturbances. So people who are anxious can't go to sleep. Um, I know there are days we're dead tired. We go to sleep 9, 10 o'clock at night, 2 or 3 o'clock in the morning, we wake up. We're going to clinicals. I can't go back to sleep. That always happens with me on the days that I got students who are doing med passes for the first time. I'm like, oh my gosh, this is going to be a tough day. So we're going to go through it. But sleep disturbances happen. Muscle tension, we become rigid, we push, we brace up. We have that fight or flight thing going because we're anxious, right? We don't know what's coming on. We can become very irritable and not very pleasant to be around. We're short-tempered. We jump on people, um, and for no reason at all. Cognitively wise, we can't concentrate when we're amped up. When you're really anxious and you're really at a high stress level, you can't hear anything, you can't focus on anything. It's hard for you to concentrate. A lot of patients, the way they handle anxiety is they sleep. They're always tired. So when you go in that room, how you feeling today? I'm just tired, Pete. I mean, this thing's wearing me out. This process is just, I didn't think I would face this ever again. So fatigue. And then restlessness. They just can't get comfortable. They're fidgeting. They're moving in the bed. They're getting out of the bed. They're walking around the room. They're anxious. Their anxiety level is high. So those are the clinical manifestations, the signs and symptoms that you'll see. In our assessment of the patient, our observation, when we go in there, we're going to look for their physical symptoms. Are they breathing properly? What's their heart rate? What's going on? What do we see? What's their medical history? Very important to know because if they're in there for diabetes, but they have a CHF condition also, we've got to know that with hypertension and everything else. Family history. Good psychosocial family history, understanding what has happened in the past with their family, genetic inclinations. Those are all big things you check for. Emotional and psychological well-being. How are they emotionally? How is that family coping? How does that family deal with the pressures that they're in? How do they feel like they're doing? Their social well-being. What are the things that are around them that allow them to be able to do the things to support them, their outside support status. Socioeconomic pressures, money again, relationships. Um, are they going through some pressures at work? Are they going through some pressures with their family members, with their children, with their grandchildren? Okay. I mean, I know my wife and we've got three of them now, and sometimes she gets very concerned, very upset about them when they're not feeling well or when something's going on. So, any type of those, it could be economic, it could be, just anything in the family, and then home and work conditions. So a good, and all of this is under psychosocial, right? We want to get that along with a little bit of our physical. And then our focused assessment. So if they're having trouble breathing, if they're feeling palpitations, if they're having headaches, if they're tingling in their toes and their fingers, we need to do a good physical assessment. And remember, a physical assessment, a good nurse with a good physical assessment will be able to tell that something's coming on before the whistles and the bells start to go off, before that SpO2 starts to drop. If you do a good, if you notice that there's crackles at the bases of those lungs, you're probably going to catch it before that patient goes into a breathing issue, breathing distress, anything. If they're having an irregular heart rate and you're picking it up, and you're probably going to catch it before their heart rate starts to go 120, 130, 140, 150. Catch it early. So do a good, focused physical assessment on that patient. So what can we implement? What kind of therapies can we do independently? So table 42.2, box 42.1, page 2075. With mild anxiety, we just want to talk to them. We want to ask them what they're doing. What type of coping mechanisms are they dealing with? How can they modify their behavior to help with these stressors that they got? So it's just kind of basic counseling, helping them work through things, reinforcing, praising them, giving them hope, letting them know you're there to help them, just being there in a support mode with the mildly anxious person. When they get to be moderately anxious, that's that patient that's restless. That's that patient that starts to show some increased respirations. Their heart rate may not be above 100, but they're usually in the 70s or 80s. Now it's up in the 90s. Respirations aren't off the chart. They're just elevated. They may be a little bit diaphoretic, but they're getting there. They're amping up. So we need to kind of look at other things. So we try to do some cognitive reframing, trying to focus them on this isn't such a bad thing. They may need to get up and walk. They may need to get out and do some physical exertion. They got a lot of catecholamines that are being released into their system. So, I mean, if they're able, if they're able to walk around the unit, or if they're at home and they're experiencing this, they may want to go do a run. They may want to go work out. They may want to do other things that physically will help them to control this. So that moderate anxiety is a little bit, that cognitive reframing is a big deal, but those catecholamines have to be burned off some kind of way. So physical exertion. Severe anxiety, this is trouble. I mean, this is where they're not listening, they can't understand you, they don't know what's going on, they're standing up, they're yelling at you, they got the IV pole in their hand, they're getting ready to hit you. They're off the chart. So we have to isolate that distressed patient. We have to provide safe and quiet and a protective environment for them. So usually when they get to this point, we don't want to restrain them if we can help it. We'll try to talk them down. We'll try to get them to get in bed or to sit in their chair or something. But now they're a harm to themselves or a harm to us. So In a hospital setting, you'll usually have sitters. Those are CNAs or techs that may be assigned to sit at the door and watch that patient, that they don't harm themselves, or if when the nurse is in there or when the doctor's in there, that they're not going to harm the doctor. There's always that extra pair of eyes on patients like this. So severe anxiety, we want to be sure we um, we help with that, that we don't have those situations. Clinical manifestation and therapy. So we are looking at a little chart here, that I kind of put together for y'all, and it's what are we going to do when we're in mild anxiety? Remember, anxiety is a continuum. So just think of a big line starting on the left and going over to the right. Low, mild anxiety is probably good. Moderate kind of pushes us a little bit higher, and we got to be watching out for what's going on. And then severe and panic is not where we want to be. So with mild, we have increased questioning, mild restlessness, increased alertness. We're able to learn. This we're usually in this mode when we're studying, when we're preparing for exams, when we're dealing with things we got to deal with on a day-to-day basis. So it's usually where we live, and it's not a bad thing. I mean, some people can't get things done until they get into a mildly anxious mode. So mild anxiety is that type of environment. Moderate, now we get into rapid speech, voice tremors, high pitch. Motor, you're going to see tremors, facial twitching, shakiness. Their attention is still focused, but it's not as good as it was before, and learning becomes impaired. And then you get that you get a slight increase in their circulation and respiratory and mild gastric symptoms. Um, so this is not where we want to be for the test, but this is where we could be if we're on question number 10. We don't know at question 11, question 12, question 13. As we go up the ladder and we say, oh my gosh, I was at mild anxiety when I walked in here. The last 5 questions, I don't know where they came from. It amps us up. We go up. Then we get to question 15, and it's Mr. Keller's easy question, and we got it right in question 16. So you'll come back down again, hopefully, with that moderate. Severe, you can't understand, agitated, inability to relax. You can't focus. You're not able to learn. You become tachypneic, dyspneic. You have palpitations. You have feelings of dooms, paresthesias, sweating. So these are all signs and symptoms of that severe patient. This patient has to be isolated. This patient has to be treated like they will have, that they're going to hurt themselves or they're going to hurt somebody else. So we want to fix that. We want to make sure we get them taken care of. Be very familiar with this chart because you need to differentiate between mild, moderate, and severe in your assessment process. And then you would need to use these words to do your documentation. Here are interrelated concepts, pretty much the same one we've had for the other 2 concepts. Cognition, communication, perfusion, metabolism's thrown in here, mobility's thrown in here, oxygenation. Sexuality is a big thing here. A lot of people handle stress with sexual types of things. So, you need to be aware of that you'll hear some things sexually from anxious patients that, once again, they trust us. They tell us a lot of things. So don't be surprised about that. Teaching and learning is also here in behaviors. So, so be aware, once again, with your care maps and your care plans, that you can use any one of these concepts that you have out there, and you can work up a good care plan on any one of these if your patient is manifesting any any problems with these concepts. Well, thank y'all for listening, and I hope everything goes well on test 4. If you need anything from me, email me. Um, Probably would be the best way. I'll look at discussion board, but that's not my strong suit. So email me, and I'll be glad to answer any questions. And I'll try to monitor the discussion boards as well as I can. Thank you, and hope everything goes well.